You're not going to come in here and learn this stuff just for the 12 hours of work. It ain't going to soak in through osmosis.
It's easy to do a lot of things that are higher reach but lower yield.
In an ambulance or a helicopter, it's a different ball game.
If you give yourself permission not to know stuff and not to be good at stuff, then you'll learn a ton.
Don't rely on your organization to be responsible for keeping you competent. Don't be that person that's sitting there waiting for somebody else to do it. As I say, get it your damn self.
Here you on 8. You on 8. Okay, you're clear. Stand by for your base.
Welcome back to Loud and Clear EMS Guiding Principles, where we dive deep into educational topics but connect those lessons back to a set of guiding principles so that you never lose sight of what actually matters in the moment. I'm your host, Ross Orpet. I'm a former paramedic turned ED doc, and today we have a special episode. We are pulling one from the vault, a conversation recorded last year at FAST24. If you guys haven't heard of FAST, it's one of the premier critical care continuing education conferences, and I highly recommend you check it out. It's a great 3-day educational conference put on by the folks at Flightbridge ED. FAST25 is coming up this May 19th through the 21st in Lexington, Kentucky. And Flightbridge ED is giving our listeners 10% off. So if you use the promo code Loud and Clear, that's loud ampersand clear, you can get 10% off of your entry fee. And you can find that in the show notes below. And I love me some bourbon, so you know I'm not going to miss an opportunity to go to Lexington. Will and I will be there again with a table interviewing some of the educators after their talks. So if any of you plan on attending, we would love to meet you. Please stop by our table and say hi. Now, last conference, as you know from our previously released episodes, we had some fantastic conversations with the educators. And these two conversations I'm about to share with you come packing more than 60 years worth of combined pre-hospital experience and leadership. This episode is a little different from our usual educational content, but given the resumes of today's guests, I wanted to take this opportunity to dive into the world of clinical education with these legends in critical care transport, Allen Wolfe and Michael Frakes. Allen Wolfe is the Director of Education for LifeLink, a seasoned critical care transport nurse, and the author of Patient Transport Principles and Practice, a textbook that's become the go-to resource for transport medicine training. Michael Frakes is the Director of Clinical Care at Boston MedFlight, a paramedic turned nurse who's been flying, driving, and leading the world of transport medicine since the 90s. These two have spent decades both on the front lines and in shaping the next generation of providers. And let's just say they've seen a thing or two. So I took this opportunity to learn from that wisdom. Over the years, they've witnessed what works and what doesn't in clinical education. How do we build better providers? What are the biggest lessons they've learned? And maybe most importantly, what mistakes are we still making? If you're an educator, a learner, or just someone who wants to be better in the field, stick around. This one's packed with insight, experience, and hard-earned wisdom. Lastly, if you guys haven't heard of our sponsor for this episode, the Recess Tailor, you got to check them out. Their mission is to improve patient outcomes through design. Instead of trying to figure out how to puzzle all of your equipment into some generic jump kit, why not start with what equipment you need and then design a bag around that equipment? A bag where every tool has its place and is intuitively where you need it when you need it most. Not only can you design this bag, but they will actually help you create a prototype so that you can test it out and make iterations before you make an order on the final product, assuring you get it just right. Contact the Recess Tailor at therecesstailor.com and see if they can help you start to design better patient outcomes in your system. Allen Wolfe, I've heard nothing but amazing things about you, sir. So I really appreciate you coming to chat with us on the podcast and letting us pick your brain. You are the Director of Education for LifeLink and are a long-time storied critical care transport nurse.
Yep.
And the author of Patient Transport Principles and Practice, which is as I understand it, one of the premier textbooks for critical care transport. Thanks for coming on the show.
Absolutely, man. Thanks for the invite. Really appreciate it.
And so you've been essentially a director of education in one company or form or fashion for what, like the last 15 years or so?
Actually, since 2002.
Oh, wow.
I was chief flight nurse and clinical nurse specialist, which did the education part for MedStar in DC.
Okay.
And I was there for 20 years. And I left there in 2010. In 2010 to 2020, another 10 years, I was director of education for Air Methods. And, Air Methods at the time, a little bit smaller. We had 1,500 employees and 160 bases. And now I'm senior director of education for LifeLink in Minnesota and Wisconsin.
Wow.
And so we have about 120 employees and 12 bases. So
yeah,
a lot of education all those years.
Yeah, that's amazing.
Yeah.
And I'm interested, how have you seen education change and grow over that time?
Right. A couple ways. One is just the things that are out there to assist you with education. Before, when I started, there was no PowerPoint. Everything was done in person. Skills were just done in groups, that kind of thing. It wasn't a focus on competency at the time. But since that time, a lot of adjuncts have been available to help people with skills. A lot of, especially with intubation, a lot of the technology related to patient care has changed, would force you to kind of learn new stuff. Something as simple as, it's like the checklist, right? Right now, everybody's talking about the RSI checklist, that's kind of changed how you approach things and teach people and learn. There's ultrasound. We just heard a talk earlier on ultrasound. That seems to be the next thing that people are grasping and learning, besides whole blood and all these things that has happened that you didn't normally do back in the past. Have changed medicine, but it's also changed education, right? I mean, how you approach it. So
yeah, do you think it's all been for the better? You think?
Oh, absolutely. Yeah. Oh, absolutely. And it also forces like older guys like me to kind of change to how the newer clinicians learn. For instance, this conference is very, I call it young and hip. You know what I mean? It's loud music. Yeah. People dress very, very, very casually. Some people wear sandals, jeans. So it's a different way of learning. Everything is short, 20 minutes. Some of the conferences are still at an hour. And then here the podcast. Yeah. A lot of people listen to podcasts, and so that's a different way of how younger people prefer their education. So giving it to it multiple ways, there's nothing wrong with it. Yeah. It's just some people need to hear it 7 times to get it, and this is helps you. Right. Then that's another medium for us to use.
Yeah, that repetition.
Yeah.
Sure.
Yeah.
Where do you think education still needs to go? Like where can we still improve?
I think VR is valuable, virtual reality. I think that's the next part of it. I think virtual reality has some value in that it's able to force you to critical think and do something what I call edutainment. So it's education and entertainment. So it's not as stressful, as going through SynLab when everybody's watching. It's kind of different because you got a headset. You can be sitting at a base just playing a game. But in turn, and behind the scenes, your clinical leaders can be able to see your pattern of thinking. I don't think, however, virtual reality has gotten to the point where it's valuable when it comes to skills. Like, just say if you had to just say put it in intubation, you can hit a button or two and it says intubate the patient. That's great, but there's more to it than just the intubation of the patient. You want to see all the steps involved in that checklist, or what if the patient gets
micro skills.
Exactly. Yeah. Like, what if the patient gets hypoxic? What are the things you do for hypoxic? Is the head of bed up? Is that PEEP valve on? All those things that you think to improve hypoxia when a patient's borderline, SATs are 85 to 89, 90 or something.
Yeah. What advice do you have for education directors out there who are trying to build a better program?
Right. I would say don't be afraid to reach out to ask other people. Nothing around education is proprietary.
Yeah. Steal ideas freely. Yeah.
Exactly. And one of the things that I'm proud of, I'm probably the leading expert. Not an expert in a lot of things, but one thing I am an expert in is patients with left ventricular assist devices. For decades, have been a big advocate with those patients in pre-hospital and doing a lot of education with those. And one of the things that we do at LifeLink, and I did our methods, is that we had the equipment. We had some of the equipment that the patients would have. We actually even had the loop that produces the flow, that whole thing. And I tell people when I talk about that or education, I got all that stuff from eBay. Right? Now, whoever thought to look on eBay for something? eBay has everything. I was talking to somebody today, and the guy said, hey, I bought a Centromag. A Centromag is another device used for ECMO. He said, I bought that off eBay. I heard you say it, and I got it.
Wow.
And he did the pre-con to this conference, and he used something off eBay. So for educators, I would say just look for places that are uncommon for stuff, and just reach out to other educators and say, how you doing this? Or what is competency? The other thing I would say is for educators to understand they have a role in the financial piece of the organization, the program, the ambulance service. You cannot have people on orientation forever. Because they say, well, they just don't know. They just don't know. No one's going to be a new person unless they have experience that's going to go from medic or nurse to all of a sudden rock star. It takes years to get there. They're not going to know everything. The goal is to get them where you recognize somebody is sick and intervene appropriately. That's all we need to know, right? You're not going to know every single thing. That's what your partner's there for. That's two of you. Two of you will figure it out. I guarantee you.
Yeah.
You can't have people on for months and months and months and months, because what that does, on the backside, it has financial implications to your organization. You just cannot feasibly, I think, do that. Not a good idea.
Got to allow for some growth.
Yeah, exactly. Got to get out there and do it.
Right.
It ain't gonna be perfect.
Yeah. Make mistakes.
Absolutely.
Have a partner there for backup, but make mistakes. Learn from mistakes.
Yep.
You're going to learn the most from your mistakes than anything else. So,
never do that again.
Right.
Ever.
Yeah. Exactly. All right. So what about for that partner, for that field training officer? What advice would you give them?
For the field training officer, biggest thing is patience, and you're never gonna get perfection out of someone with no experience coming into this kind of industry, right? I think too, the other piece they should probably take into account, not everybody, especially the nurses, are gonna be comfortable coming into this environment where the environment is a bigger play than anything. In the hospital, there isn't any environmental issues, because it's so controlled and it's in a room. With everybody kind of knows what they're doing. But in an ambulance or in a plane or a helicopter, it's a different ball game, because the environmental things have an impact, sometimes your decisions, And just say if you're on the ground and you get there and, you don't think it's safe, get up out of there.
Yeah. Yeah.
I'm getting in there and leaving. I could care less what happened to that patient. I got to get out of here, right? And so your safety is paramount. Safety first. Usually in the hospital means the patient. Safety to you and I means, I don't know, I'm number one, and you're number two. I'm not going to go there if it's not safe, or land if it's not safe. So that's what I would say.
It's that logistical piece that we've talked about so much again and again in this conference.
Yep. Absolutely. And our other thing for field training officers is repetition. You can't tell somebody once. All of these things. There's so much. People think you should be an expert on everything. No. But if you give it to them over and over and over, eventually they'll get it. You just have to give it to them maybe 7 times, but over. So the big stuff, they're not going to get every single thing. If you're doing RSI, what's the big things with RSI? How do you do ventilate, oxygenate them in the beginning? How to put the tube in a second? And then how do you confirm this? How do you know it's in the right spot? If I had to pick 3 things, I would make sure they understand that piece, and that piece, and that kind of covers everything.
And then build upon that.
Yeah, exactly. And it's repetition. Other thing I would say for training officers is to observe more what people do and not just allow random training. Example, if at your base you require intubations every day so they can get muscle memory, you have a head at the base and whatever, you have to think of the parameter is what if they're doing it wrong every day, right? There's nobody watching them to do that. And so then they learn bad habits. And so now you've created a monster. And so what that field training officer needs to do is, or educated me to do, is put parameters in where somebody is able to control the quality of it. Maybe it's a partner or somebody there to watch it, to make sure the details that they are not intubating with the blade, in their right hand, whatever. They could do that. And what's wrong with this hand, And so I think that would be helpful.
It's that idea of practice doesn't make perfect, but perfect practice makes perfect.
Right.
Yeah.
Right. Yeah.
So for that trainee then, moving down the line, what recommendations do you have for the trainee as he's learning? How can he learn better?
A couple things. Have a lot of ideas. Yeah. One is that you got to burn the midnight oil. You're not going to come in here as a new person and be a rock star in the beginning. You're not going to come in here and learn this stuff just for the 12 hours of work and the 24 hours that are working. You got to, when you go home and sitting there, and once your kids go to sleep or you're by yourself, you have got to learn this content in this industry. It ain't going to soak in through osmosis. The other thing, too, is that where you work, if you're a nurse or a paramedic and you're looking for where I should work so I can get the job of critical care transport, I would say go to a place where you're afraid your car is going to be stolen. I parked in the parking lot and the whole shift you worry about your car. That's the place to work. When medics ask me, and medics who go to nursing school and become a nurse, they go, I'm not sure where I should work. I'm working in my house and, some rural area. I go, hell no. You need to go where you are worried about that car being stolen. Because why? That's where all the good stuff comes. As far as trauma, that is where they come is in these cities.
Yeah.
And that's where people who have these complex things with moon eyes and humpback, all these different things that are medical going on with them, they end up being referral. John Hopkins in downtown Baltimore. You got to come in there, you know what I mean? So you're able to see that stuff. Otherwise, you wouldn't see that stuff at some smaller ER. You're working in a rural suburban place. So go to a place that's going to challenge you at the cream of the crop. So now your base, what you initially learned, is just helpful to you when you get that other critical care ground job or air job because you have something to pull from.
Yeah.
Don't shoot yourself short by just getting just the requirement at some place that's not very hot to do that. You know what I mean?
Yeah. Build that foundation.
Yeah, man.
From
Absolutely.
The beginning.
Absolutely. Get the best spot. I can remember working in DC, at a place called DC General, and one time we had 13 shootings in 1 hour. This is back 80s during the crack wars kind of thing. And I would go, God, that was good stuff. You know what I mean? It was crazy while I was in there, but I saw everything. This 15-year-old kid came in with shortness of breath. Couldn't figure out why. He was just, I don't feel good with shortness of breath. Just walked in, got an x-ray. He had 100% collapsed lung on his left side. Spontaneous collapse of his lung. Who would ever think you would just collapse a lung just walking? He had no trauma, nothing. It just collapsed, And it's things like that you see, or a C2 fracture, hangman's fracture. So walk to the door, stable. So I'm having some pain in my neck. They go, okay, lay down, pull a counter on.
Yeah.
And it's somebody who tripped and fell down, but had a C2 fracture and walked in the door. Things that you just learn from the whole assessment piece, the workup. Do they have deficits? What's the things you have to worry about with them? All that stuff you learn from when you go to a place where you're scared. Where security is walking you out to your car. You know what I mean?
Absolutely.
You know what I mean, dude?
Yeah.
So.
Where the elevators don't fit the stretchers.
Dude, exactly. Dude, exactly. Is that where you want to be?
Yeah. That reminds me of a case that I had where a guy, ground level fall, he fell the night before. It was like 50-year-old guy, got no medical problems. And I show up the next day or he calls 911 the next day because he's in too much pain to get out of bed.
Yeah.
And I do a neuro exam while he's laying in bed. He's totally neurologically intact. I sit him up on the side of the bed. I palpate his spine. He's got no tenderness on his spine whatsoever. And so I walk him to my cot and then we transport him to a non-trauma center because he has a specific insurance that's covered by this non-trauma center. And so that's where we go. As we're pulling the stretcher out, he goes, ow. And I go, what hurts? And he goes, my neck. And he goes, every time I turn my neck, my fingers go numb. I was like, well, so we're at the ambulance bay of this non-trauma hospital. So I put a collar on him. I walk him in. I tell them he just started complaining of this. Come to find out later, he had a cervical fracture. He actually developed an epidural hematoma there. And for a period of time, he was quadriplegic. So he was walking, talking, totally neuro intact when I dropped him off. And then supervisor came to me later and said he had to be transferred emergently to the trauma hospital, couldn't move any of his extremities. Thankfully, the hematoma resorbed and he was able to walk out of the hospital.
Wow.
But the take home from that, I tell this story because this sticks in my head is even though he had no midline spinal tenderness and he was totally neuro intact, when I got him up, when I set him up off the bed or I got him and walked into the cot, he never moved his neck. He moved his shoulders and his head stays still. And he just self-splinted his cervical spine the entire time. And that image now is just burned in my mind.
Never happened again.
Yeah. Yeah, sorry for that sidetrack.
Oh, no, dude, that's awesome. That's a good
So
one.
let's say you're past the field training point now. How do you keep that burning the midnight oil or just the vision of the lifelong learner? How do you keep that up?
Right. I would say that don't rely on your organization to be responsible for keeping you competent. We know that with the cost reimbursement and just money in general, a lot of organizations aren't providing extra stuff or conferences or whatever for their employees. And so if you're one of the people, well, you know what, they don't care, I don't care, I'm gonna hit the clock, and you set yourself up maybe for making a mistake. You want to be that person that I'm gonna get it myself. If I can't afford to come to a conference here like FAST, then online is where I should do it, and some of these are rebroadcasted. Get the stuff online, but don't be that person that's sitting there waiting for somebody else to do it. Just get it, as I say, get it your damn self. And I say to people when I was at Air Methods and did orientation, I said, no one said, Allen Wolfe, you should be the VAD expert in the industry. Nobody said it. What I did is like, oh, I like this little device, and I learned it, and I looked at it again and again and again and again after years. All of a sudden, I know it like nobody else, So you become an expert on something, and whether it's airway or ventilation, whatever it is, some of this stuff, you have got to get it yourself. Somebody's not going to sit here and go, well, hey, what you don't know today? They're just not going to do it. I don't do it now at LifeLink and say, ask everybody, hey, what you don't know? Yeah. What I do is create simulations, and I look and see what you don't know, and see if that's a trend between a lot of people, or is that just you,
Yeah.
And so that's helpful.
Yeah, you're responsible for your own education.
Absolutely.
And I mean, that's good advice for field trainees, field trainers, even as a trainee, that you have a structured program, you're going to get out of it what you put into it, right?
Absolutely.
Yeah. Well, thank you so much.
Thank you, bud. That was awesome.
Yeah. Any other words of wisdom from your career that you would depart?
Dude, nothing but learning is lifelong.
Yeah.
I still don't feel comfortable with some things. Some things I really feel comfortable with,
Yeah. Awesome.
But that's okay to do that. So
cool. Thank you.
Bud. Thank you, man.
My name is Michael Frakes, and I'm the Director of Clinical Care at Boston MedFlight. And I'm old, so my career is long. I started out as a non-medical person. I have a college degree in economics, which either positions you to do a lot of jobs or no jobs. And medically, I started working as an EMT with the fire department, and then worked as a paramedic with the fire department. I loved being with the fire department. Great job. 911, work on an ambulance was a great job. So naturally, I left what was a good job, went to nursing school, and went into the hospital, worked in the emergency department and the intensive care unit with both adults and kids, all with the goal of coming back to critical care transport. So since 1998, I've been doing critical care transport in some form or another. At Boston MedFlight now, we're a fully integrated team. So every clinician does newborns, kids, and adults, interfacility work, scene work, and works in our helicopters, ambulances, and airplane.
Over your career, what's the best change you've seen in education, how we provide it?
I think that it would be hard to pick one. I think that the first best change is that the community overall is a lot more focused on evidence and science, and is a lot more focused on doing things that we know are helpful or know that work. And so I think that that's great. I think that provider curiosity is higher than it used to be. Like, there are a lot of people who are more interested or who are very interested in the medicine. And I think that a lot of that is linked to availability. So now there are great podcasts. There's a lot of distributed learning. There are a lot of ways to get access to the information that there didn't used to be. And I think that that's helped make everybody more curious and smarter and better providers. And I think that also speaks to what the educators do. It has made it both easier to be an educator because people are a lot more used to distributed learning and they don't expect you to be one-on-one. It also means that you have to try really hard to still do the in-person one-on-one stuff because people learn differently that way. And for a lot of things, they learn more that way. And for some things, the only way to learn it is to do it.
What do you think we still need to improve on? How, as an education group, do we need to get better?
We need to keep thinking about how to approach different learners. Some people learn best by reading, some people learn best by doing, some people, everybody learns in different ways. And so I think we need to make sure that our education strategies appeal to those different groups. But at the same time, we also need to think about it from the perspective of what you have to learn and make sure that our education approaches match what we're trying to teach you as well as your learning strategies. And so getting those two things to intersect is the challenge for education teams, and I think it's the key to success for education teams that do it well. I think that the technology and the changes have made it easy to be a little bit lazy. It's easy to do distributed learning. It's easy to record something and send it out. It's easy to do a lot of things that are higher reach but lower yield.
If you're the director of an education team, how do you create that type of curriculum that is a little more tailored to the learner, understanding, recognizing that everybody learns a little differently?
From our experience at Boston MedFlight, we spend a lot of time in small groups with the teams. And so each of our providers does more than 20 times a year education in a group of 3 people or less with one of our educators. That gives us the chance to identify what everybody on our team is good at, where our weaknesses are, and different learning strategies of different members of our team. And then we can get the education team back together and use all of that information to build our plans going forward. And if we've been successful, it's because we spend a lot of time with all of the team assessing their strengths and weaknesses and styles and assessing what our organizational needs are.
What about for that trainee? What advice do you have for them?
Don't be afraid to be wrong. When you come into critical care transport, you're not just learning how to do the same job in a different place. You're learning how to do a new job in a new place. And your orientation is the free pass you have to ask every question and make every mistake and try everything in a free space. Everybody who comes into critical care transport is a high achiever and is a sort of mistake resistant. If you give yourself permission not to know stuff and not to be good at stuff so that you have the experiences to learn stuff, then you'll learn a ton.
What about once you clear that trainee position? Now you're out on your own. How do you continue to learn and get better?
It's a lot harder once you are out in the general population. The expectation is that you know the job and you perform, and you don't have the safety net with you. I think that you continue to get better by always being curious and by always being humble. The work that we do is absolutely fascinating. We review every single case that we do at Boston MedFlight. That's part of my job, is I review a ton of cases, and they're just fascinating. And if you have the curiosity to say, hey, this case was very interesting, I'd like to know more about X, then you learn a lot of stuff. And if you're always humble, then you know that you're not as good as you think you are. You allow for the fact that there's stuff you don't know. You allow for the fact that you're going to do better. And so if you and your partners are always curious and always humble, that comes up as you debrief every case. You learn stuff and you find things that you need to learn.
Thank you so much for joining us and
Sure.
giving us those tips of wisdom.
All right. Thanks so much for having me.
As we close out this episode, I want to just summarize my key take-homes from these 2 discussions. If you're in the field, you're not going to be a rock star on day 1, and you're not going to learn by osmosis. You have to take charge of your own education. You are only going to get out of it what you put into it. So not only do you need to burn that midnight oil in the beginning, but you also need to adopt the attitude of being a lifelong learner. You need to maintain a level of curiosity to say, hey, this case was really interesting. I'd like to know more about X. Be humble and allow for the fact that there's stuff you don't know. Then go chasing that learning. When you do hands-on practice, make sure you do so deliberately, breaking down each skill into their micro components. Coaches and mentors are invaluable to help make sure you are practicing the right way. Practice doesn't make perfect. Perfect practice makes perfect. And when you're in the orientation phase, take full advantage of that. Don't be afraid to be wrong. This is your free pass to ask every question, make every mistake, and try everything in this free space. Most of us are mistake resistant, but if you give yourself permission to not know stuff and to not be good at stuff so that you have the experiences and be open to learning, then you'll learn a ton. If you're in education, realize continuing education has changed, and mostly for the better. Everyone may find engagement in different learning styles. Find what works for you and double down on it. Utilizing small group trainings in your agency can really help individualize your training by assessing personal strengths and weaknesses and tailoring your education. And more now than ever, we should be leveraging technology to our advantage. Things like distributive learning has brought what used to be difficult to access learning to the masses. And things like virtual reality are going to push that even further. But at the same time, as great as all that is, it can be a trap to hit the easy button and do a lot of things that are higher reach but lower yield. We also need to be deliberate about practicing hands-on skills. This can be more difficult to organize, but cannot be ignored because these skills are just as important as the cognitive skills. If you're an educator, steal freely. There are so many great resources out there and so many great educators who are more than happy to pass along the trainings and protocols that they have developed in their own agencies. Stay curious, stay humble, and keep learning. And if you're interested in attending the FAST24 conference this May in Lexington, Kentucky, don't forget to use promo code LOUD and CLEAR to get yourself 10% off the entry fee. That's loud & clear. You can find that in the show notes. And if you're out there, don't forget to stop by and say hi.